Next up on our women's health panel, we have Dr. Wilson King, who again is a board certified obstetrician and gynecologist who is now practicing integrative wellness medicine, which she has been practicing for the past 10 years. She is also a board member of the Doctors for Cannabis Regulation and co-vice president of the Society of Cannabis Clinicians. So we are very pleased and excited to have her here today. She is going to be giving us a women's health presentation on cannabis and the connections that cannabis and women's health has. So Dr. Wilson King, I'll let you take the floor. Thank you so much.
Thank you. Good afternoon, and I want to thank Canna Health for that wonderful introduction, and Erin Allen's presentation before was beautiful, just what I needed before doing a webinar. It's an honor to be a part of this virtual event. And today I'm going to speak to you about how cannabis can be helpful in managing some of the conditions that are specific to women. I'm going to share my screen and put my slides up. Oh, here we go. Slideshow. There we go. All right. The objectives of this talk, first, I want to make sure I inform you that, as Brittany already mentioned, that there's a history of cannabis use in women's health. I'll do a brief discussion about cannabis and pregnancy, and then we'll talk about how cannabis can be helpful for endometriosis and dysmenorrhea. We'll touch on how cannabis can affect your sexual health, talk a little bit about cannabis use disorder and withdrawal, and I'll explain some of the gender differences in the effects of cannabis. And yes, there are differences between women and men in the effects of cannabis. Now let's dive right in. One of the first, in a paper entitled Cannabis Treatments in Obstetrics and Gynecology, published in 2002 by Dr. Russo, he describes physical evidence to support the presence of medical cannabis use in the geographical area known as Israel and Palestine today, but this was in the 4th century. They found a skeleton of a 14-year-old in a burial tomb along with 4th century coins. That's how they knew it was 4th century. The baby was still, of course, the remains, the baby was still in the woman's pelvis, but they also found gray carbonized material in the abdominal area, and it was analyzed and found to be phytocannabinoid metabolites. The author of that article stated that we assume that the ashes found in the tomb were cannabis, burned in a vessel and administered to the young girl as an inhalant to facilitate the birth process. Now, the paper illuminates the fact that cannabis has been employed historically for many conditions in obstetrics and gynecology. And to list a few of those briefly, there's dysmenorrhea, menorrhagia, threatened AB, threatened miscarriage, hyperemesis gravidarum, preeclampsia, menopausal symptoms, all sorts of things. Now, let's talk about cannabis use in pregnancy. The foundation of a healthy pregnancy. I want to make sure you get this, because Dr. Wilson King is not recommending that you use cannabis during pregnancy. The foundation of a healthy pregnancy, the best things for pregnant women to ingest are healthy, whole, real food, clean water, and fresh air. Avoid processed sugar, processed foods, and foods with no nutritional value. It is advised not to ingest or smoke drugs of any kind, including tobacco, alcohol, caffeine, opiates, methamphetamines, cannabis, and pharmaceuticals. Now, there was a National Academy of Science, Engineering, and Medicine report. It comes out about every 10 years. The most recent one was in January 2017, in which they reviewed more than 10,000 studies looking at cannabis and its potential harms. Most of the studies were done since 1999, most. And in all of the studies, the participants smoked cannabis. There's an entire chapter on prenatal, perinatal, and neonatal cannabis exposure. Now, this can be found online, and I'll send anyone a link if they would like to see it. The report found that there was substantial evidence of a statistical association between cannabis smoking and lower birth weight. But they found that these findings were more consistent with the fact that the patients were smoking rather than due to the cannabinoids in the cannabis smoke. So, but as I said, you shouldn't smoke anything during pregnancy. There was limited evidence to suggest anything that would affect the mother during pregnancy. And there was also insufficient evidence to show that cannabis affects children in later life. The bottom line is we do not know, really don't know the adverse effects, if any, of cannabis use in pregnancy. There is no known safe amount of cannabis to use during pregnancy, and there's no known unsafe amount to use in pregnancy. The point is, don't use any. But my bottom line is women of reproductive age need to be counseled and educated on the use of cannabis during pregnancy in the pre-pregnancy or early pregnancy period. They should not be criminalized or threatened with the loss of their children or with incarceration, period. Now I want to talk a little bit about cannabis and endometriosis. Endometriosis is defined as the presence of endometrial tissue outside of the uterus. It's accompanied usually by a chronic inflammatory reaction around the site where the tissue. Now, when I say endometrial, that is the lining inside the uterus from which the menstrual period comes. So that's that innermost lining of the uterus. That tissue gets extruded to other parts, to the ovary, to the tubes, even into the abdomen. The prevalence of endometriosis is about 10 to 15%. And it is something that significantly affects the families, the partners, and the carers of those with endometriosis. And it really can be psychologically and physiologically disturbing. The cause is unclear. The importance of hormones on endometriosis is well established in that estrogen and progesterone regulate the growth of the endometrial tissue by stimulating and inhibiting the proliferation respectively. It is said that endometriosis is a disease of contrast. It is benign, but it's very locally invasive. It can really spread to all parts of the pelvis. Cyclic hormones stimulate growth. So women who are still having menstrual periods will have periods of time where they're in a lot of pain because of the stimulation of the hormones, and the hormones are stimulating growth. Usually it's estrogen. Continuous hormones actually suppress growth. Now let's look at the symptoms. 70% of women with endometriosis have dysmenorrhea. In fact, endometriosis is the most common cause of what we call secondary dysmenorrhea. Primary dysmenorrhea is usually in adolescence and usually occurs 6 to 12 months after the first period, whereas and usually there's no pathology in primary dysmenorrhea. Secondary dysmenorrhea, usually there's usually some pathology. Now the symptoms can include abnormal menstruation, infertility, dyspareunia, chronic pelvic pain, back pain, and abdominal pain. Patients with endometriosis often suffer low, diffuse, and poorly localized pain. When you ask a patient where does it hurt, they usually just rub their hands across their entire lower abdomen and pelvis and say all in here, because that's what endometriotic implants do, as you can see on the picture. The current pain management strategies for endometriosis include medical and hormonal therapy, as well as surgery. Medical management of the pain is really insufficient and hasn't been associated with a high rate of of relief. The National Academy of Science, Engineering, and Medicine report I just referred to earlier does state that there is substantial evidence that cannabis and cannabinoids are effective for the relief of chronic pain. Therefore, cannabis is a potential treatment for the symptoms. The degree of pain in endometriosis is not generally related to how much endometriosis you have. In my clinical experience, I've done surgery on patients and found the pelvis full of endometriotic implants, and they never complained of pain. Or I have had patients that come in complaining of severe pain, and we do a look-see inside of the abdomen and find maybe 1 or 2 endometriotic implants, and that's it. So the degree of pain is not related to the severity of the endometriosis. It commonly flares up between the ages of 30 to 45, in many patients that have never been pregnant or had children at a late age, and oftentimes there's a family history of endometriosis. Now, let's look at how the endocannabinoid system does play a role in endometriosis. In recent years, the endocannabinoid system has gained interest in endometriosis research. The endocannabinoid system is located in the endometrium, the myometrium, the ovary, all throughout the female reproductive tract. It also has important roles in the menstrual cycle, ovarian maturation, embryo transplantation and implantation. And the endocannabinoid system has been shown to affect specific mechanisms critical to endometriosis establishment and maintenance. Now, and also the endocannabinoid system is really, really important in fertilization. There was a study published in November of 2019 looking at the role of the endocannabinoid system in the origin or creation of endometriosis. And it found that the uterus contains the highest concentration of AEA. Now, AEA is anandamide, and that's one of the body's internal cannabinoids. Yes, the body makes what's called endocannabinoids. The other endocannabinoid is called 2-AG. I'm just talking about 2 of them. There are others, but we have characterized anandamide and 2-AG much more than we have others. The part of the endocannabinoid system consists of anandamide and 2-AG, the endocannabinoids. It consists of the receptors, cannabinoid 1 and cannabinoid 2, and it consists of the enzymes that synthesize the endocannabinoids and enzymes that take away or remove the endocannabinoids. So that's why I've said that CB1 and CB2 receptor levels are lower in patients with endocannabinoids, with endometriosis. And the levels of endocannabinoids are significantly higher overall and by phase in women with endometriosis. Patients without endometriosis show no difference. CB2 receptor expression is significantly higher as well, and local inflammation plays an incredible role in the beginning of endometriosis and in pain. Now, there was a mouse study that was done. They were looking at how THC can affect endometriosis, mainly the pain associated with endometriosis. Cannabis, let me give you a better introduction than that. The women who undergo surgery to remove the growths may experience post-surgical pain or recurrence of their endometriosis. And hormonal therapy puts one in a state of hormonal deficiency, and that's not always fun with endometriosis. It makes you menopausal, and that's a little bit difficult to live with. Another potential treatment is vaginal Botox injections to manage the pain. I think that's a bit aggressive, but some women are in that much pain and need help with their relief. But cannabis could be doing more than that. This group created a mouse model that mimics the conditions of human endometriosis in these mice. They could exhibit pelvic pain, anxiety, and they developed a way to measure cognitive impairments. Then the mice were treated with THC at a dose of 2 milligrams per kilogram per day for 28 days. 28 days. So THC, which is delta-9 THC, the psychoactive component of cannabis, but certainly not the only component of cannabis, because we all know cannabis is composed of over 100 different cannabinoids, over 400 different compounds. We have terpenes, we have flavonoids, we have omega fatty acids, we have all sorts of wonderful things in cannabis. Now, the researchers found that THC reduced pelvic pain and improved cognitive impairments in the mice, but it had no effect on their anxiety. So they also noticed, and I'll show you in the next slide, that the endometrial growths decreased in size. Now, these experiments suggest that THC may be a very useful treatment for patients with endometriosis. Animal studies, however, do not necessarily translate to human effectiveness. Clinical trials are ongoing, and we need more studies to see what's happening. There was a study, it was more of a survey done in Australia on women who were diagnosed with endometriosis and what they did for self-management. Many of them used, I think it was 40-some% used cannabis and rated cannabis relief at a 7.6 out of 10. Most of them smoked cannabis, and I can bet you if they had been followed by a physician who knows cannabis, they would have had, I have higher outcomes in my patients because we don't just use smoking. Cannabis has all different routes of administration, and people need to learn about them and utilize some of the other routes of administration. But at any rate, cannabis use in endometriosis needs to be studied more. This next slide shows you a picture. The picture on the, it's my left, is the endometriotic implant before THC. The picture on my right is endometriotic implant after the treatment of THC for 28 days. Fascinating, isn't it? Now, the other question then is endometriosis an endocannabinoid deficiency condition? Now, clinical endocannabinoid deficiency was first presented by Dr. Russo in 2002. This theory suggests that in some cases, the body doesn't produce enough endocannabinoids or enough receptors for the endocannabinoid system to function properly. As a result, many functions aren't regulated properly and the body becomes unbalanced, allowing diseases to arise. Now, in Dr. Russo's initial paper, he looked at irritable bowel syndrome, fibromyalgia, and chronic migraine headaches. This next study that's on the slide, mentioned on the study that was done in 2019, looked at the associations between endometriosis and irritable bowel syndrome and whether concurrent pain disorders affect these. The study found significant associations between endometriosis and irritable bowel syndrome. In fact, there was a clear linear relationship, such that the more severe and frequent the pelvic pain, the more likely the participant would also have IBS. Subsequent research has confirmed that underlying endocannabinoid deficiencies indeed play a role in IBS, migraine headaches, and fibromyalgia. And there's a growing list of other conditions like endometriosis that fit into this category. I find that incredibly fascinating, and that may be why cannabis is so helpful to women with endometriosis. Now, how do we treat? What do I do with a patient when I'm treating them for endometriosis? First of all, my treatment always involves a holistic approach. We talk about diet. We talk about an anti-inflammatory diet, meaning you're going to eat real food, nothing with a lot of chemicals or preservatives in it. If it says apple, it is an apple. If it says spinach on the package, that's the only thing that's in there. Exercise, meditation, Tai Chi, all sorts of things. There's actually some yoga is also very good, because there are some specific yoga poses that are geared toward relieving pain in the pelvis. Now, when I use cannabis to treat my patients, I can use any type of cannabis, type 1, which is THC dominant, type 2, which is a balance of CBD and THC, or type 3, which is CBD dominant. All of them have worked on various individuals. The beauty of cannabis is that you have to find what works for you. One thing doesn't work for everybody. Also, there are different modes of delivery of the cannabis. There's the tinctures, there's capsules, there's oils. Smoking isn't the only method. Certainly, and if you're going to smoke, I would suggest you I was just not smoking and vaporize the real flower with a vaporizer, as opposed to vape pens and smoking. That's actually a little bit safer. The other really nice finding in the treatment of endometriosis in women is considering the use of vaginal suppositories. They work really, really well. Now let's talk about dysmenorrhea. The word dysmenorrhea literally means painful menstruation, but a better definition is painful menstruation that is disruptive to normal life. And there are two kinds, as I stated earlier: primary dysmenorrhea, which usually starts in the adolescence within 6 to 12 months of the onset of having periods. And the pain is generally with the menstrual period and has no pathology usually. Secondary dysmenorrhea commonly occurs in the 30s or 40s. The pain is 7 to 10 days before the period, could be 7 to 10 days after the period, could be during the period. Some women only have maybe a few days per cycle where they're pain-free in some forms of secondary dysmenorrhea. 80% of women experience dysmenorrhea, with 20% having severe cramping that interferes with life. Now, let's look at the endocannabinoid system and dysmenorrhea. Now, cannabis has been known to be used for dysmenorrhea for thousands of years. There are cannabinoid receptors in the female reproductive tract. The endocannabinoid system plays a clear role here, and cannabis is effective for pain. But dysmenorrhea is intermittent pain. So studies definitely need to be done to show how cannabis is effective for menstrual pain. And as I said earlier, the uterus has the highest concentration of anandamide, and levels of anandamide fluctuate based on whether you're in the estrogen part of the cycle, the progesterone part of the cycle. Now let me explain that quickly for a few minutes. From the first day of your period until ovulation is called the follicular or proliferative phase, and that's managed by or overseen by estrogen. The second half of the cycle, from ovulation to the onset of menstrual period, is overseen by progesterone. And that's when progesterone is calming things down and preparing things for fertilization. When fertilization doesn't occur, both hormone levels decrease and you have a menstrual period. So the levels of anandamide are influenced, they're stimulated by estrogen and decreased by progesterone. Anandamide can be produced in the ovary. Now, what's the treatment for cannabis use in dysmenorrhea? Again, you start with a holistic approach, and oftentimes that will be helpful. We're not sure why cannabis is effective, but it is effective. Again, different routes of administration. You don't always have to smoke it. And smoking, yes, it's rapid onset, but it only lasts 2 to 4 hours, where if you use some of the other modes of delivery, you get longer lasting effects, such as tinctures, suppositories, capsules, even edibles. And all types of the cannabis cultivars are effective. Now, let's talk about cannabis and sex. Don't everybody get excited at once now. There's a lot of anecdotal evidence when it comes to cannabis and sex. Cannabis can stimulate the libido in both sexes. For women, cannabis can increase vaginal lubrication. You might say, It makes my mouth dry, but it's not going to do that to the vagina. It's the same tissue. Cannabis has an effect on the salivary glands, and that's why it makes your mouth dry. It doesn't affect all the other mucous membrane surfaces throughout the body. So therefore, cannabis can increase vaginal lubrication, decreases anxiety, leading to muscle relaxation. It can also relieve painful intercourse because it is a pain relieving. There are no apparent dose-related issues, though always with cannabis, less is more. Cannabis can help overcome the sexual dysfunction that's associated with the antidepressants, and inhalation and using a vaporizer is the best mode of delivery when it comes to sex. Now, for men, cannabis is dose-related. The effects of cannabis on their sexual ability is dose-related. Low doses are helpful with erections and ejaculation, the ability to attain and maintain an erection, as well as help with ejaculation. But high doses do the opposite. So men have to be careful of their dosing when it comes to sex, whereas women, it's not so dose related, but less is more, and it's also less expensive if you have to use less. Have to always think about the economics. So with cannabis and sexual health, it has the least amount of research of all. And cannabis users, Dr. Michael Eisenberg, who I'm working with on another study, did two studies, one in which he looked at the frequency of sex in cannabis users versus non-cannabis users. Cannabis users had a higher frequency of sex. Then he also looked at, in 2018, does cannabis affect the ability to get pregnant? Because cannabis use is oftentimes listed as a cause of infertility. His results, when he compared cannabis users to non-cannabis users, found that there was no statistically significant impact of cannabis use on the time to conceive a baby. That's big. That's huge. Now, there is a couple of other studies that have been done that looked at the role of cannabis in the experience of sexual arousal and orgasm. And they found that the levels of 2-AG increased during those periods of time. Dr. Eisenberg and I are in the process of reviewing the results of a survey we did looking at the different kinds of cannabis chemovars used, the frequency of cannabis use, and the reason for use, and the route of administration, and how it affected sexual health. We have over 325 men and more than 400 women. And we're looking at those results now, and we think there is a dose-response relationship, but that will come out a little bit later this year. And I am definitely looking forward to that. Now, there was a question about cannabis dependence. So I listed all of the other substances of use and abuse and looked at the lifetime risk of dependence. It's a paper done by Anthony et al. First in 1994 and then in 2006. You see, cannabis has the lowest risk for cannabis dependence in the realm of 9%, whereas stimulants other than cocaine, and that's like the Adderall and stimulants used for appetite suppression, things like that, the risk of dependence is 11% and on up. Now, the last one, sugar greater than 50%, I put that there because sugar is an addictive habit and has a high rate of addiction. Now, cannabis safety. It's important to understand that less is more. Cannabis works very well in low doses. In fact, many of my patients are using low doses. I even have patients come to me to help them with their cannabis. And I have one patient whose cannabis use and expense decreased by 2/3, and he was feeling so much better. So you don't have to use a lot to get your result. But in case you do use a lot, I want you to know that in a lab, monkeys were given up to 9,000 milligrams per kilogram of cannabis, of THC, and they did not die. So, an overdose of cannabis may make you feel like you're going to die, but you're probably not going to die. Do not use synthetic cannabis products. Smoking is, and I know most people smoke their cannabis, but smoking is the most harmful way of using cannabis. It's not as harmful as nicotine, but it is harmful because it does irritate the airways. During this COVID-19, I have recommended that my cannabis patients try not to smoke, or certainly smoke as little as possible. And let's explore some of the other routes of administration if they haven't yet, because COVID-19 attacks the lungs, and you want your lungs to be in as best shape as possible should you get infected with COVID-19. I would also avoid combining cannabis with alcohol, combining it with smoking cigarettes, and combining it with other drugs. Cannabis works well by itself. You can get all you need from cannabis. Please know that cannabis is a safe substance. In strict medical terms, marijuana is far safer than many foods we commonly consume. Marijuana in its natural form is one of the safest therapeutically known active substances known to man. Now, this was said in a ruling by an administrative law judge, Francis Young, after the first hearing to attempt to remove cannabis from Schedule 1. He agreed it should be removed from Schedule 1. You know what Schedule 1 means? Schedule 1 means cannabis is highly addictive. Now, I just showed you the chart. It is not highly addictive. But cannabis is highly addictive, also has no medical benefit. I just talked about the medical benefits, and there are many, many others. And that cannabis is not even safe to be used, even under the direction of a physician. All of those are untrue, but they still put cannabis there. It is definitely a safe substance, but people can overuse it and people can become addicted to it. And I'll talk about that in a minute. But I want you to also know that the use of cannabis can be for harm reduction. Studies show that that cannabis can be used to lower the dose of opioids needed to achieve relief from chronic pain. Cannabis also can prevent or blunt the development of opioid dependence or tolerance. And there's evidence that cannabis can decrease the severity of opioid withdrawal symptoms. There have been no verified cases of death from cannabis overdose. That is big, and I want everybody to make sure they know that. Now, there's an entity called cannabis use disorder. They don't call it dependence anymore or anything like that. It's substance use disorder. And they put the alcohol use disorder, nicotine use disorder, everything's in use disorder. So cannabis use disorder is a person has to have been using cannabis for a year and exhibit any number of the following symptoms. It's classified mild, moderate, or severe based on the number of symptoms you have. Some of those symptoms are repeated failed efforts to discontinue or reduce use. You just can't stop using it. Or an inordinate amount of time is occupied looking for cannabis, using cannabis, or recovering after its use. You ignore other important activities in your life because of your desire to use cannabis. That's over the top. Cravings or desires to use cannabis. Using cannabis in situations that are potentially dangerous, like getting high and then getting in the car and driving. However, most cannabis users probably don't do that because they can't find their keys. That's meant to cause a little laugh. At any rate, like I said, mild, moderate, severe. Mild is 2 or 3 symptoms. Moderate is 4 to 6. Severe is 7 or more. And the prevalence of cannabis use disorder is it decreases with age. It's highest among 18 to 29-year-olds and is lowest among people 65 years and older. Now, some of the signs of cannabis withdrawal: anger or aggression, decreased appetite, weight loss, irritability, anxiety, restlessness. The good part about this is the symptoms appear maybe 1 to 2 days after cessation, and it usually resolves within 1 to 2 weeks. So, and this is my opinion, but there is supporting evidence. I believe cannabis use disorder is something that we created when we created the highly concentrated cannabis forms such as shatter and things like that. The highly concentrated types of cannabis, just all THC all the time. We created cannabis use disorder. If you just use cannabis on a regular basis to help you sleep or to keep you out of pain, to help your endometriosis, you're probably not going to have a problem with that. Now, I did mention earlier that there are gender differences in cannabis use, and a review of animal studies suggests that the differences in cannabis, in the response to cannabis, are not just sociocultural, but there is a biological reason. Now, men are up to 4 times likely to try cannabis and use higher doses and use cannabis more often. And that's probably because of testosterone. Testosterone increases risk-taking behavior and suppresses the brain's reward system so that you need more cannabis to feel the reward you wish to feel. And it might explain why males are more likely to try cannabis and the fact that they often use higher doses. Women tend to use lower doses than men, but there is known, women are slow to try cannabis, but they will progress rapidly to a habit or cannabis use disorder. Women tend to use vape pens or vaporizers or tinctures, oils, and edibles, whereas men will more often smoke and use the high concentrates. And consider this. Oh, before I go to that, the month of March, for the first time, there was a report that dispensaries, the purchases by women in dispensaries were larger than that of men. Women spent up to $105 per purchase for cannabis, while men spent less for the first time this past March. I don't know if that has to do with COVID-19 or just what, but women have been using cannabis more and more and more. And you'll notice, if you take a look, that in the dispensaries, there's more and more products that seem to be geared toward women. Now, despite the slightly lower average use, women go from first hit of cannabis to cannabis use disorder faster. Women are twice as likely to report their first cannabis use after age 30. Women generally have a specific reason to use cannabis, while men do not. Now, I don't know anybody who's surprised at that. Smile. As I've stated throughout the talk, though, that estrogen is the reason for these differences. We do need to do much more study to fully assess these findings. In summary, cannabis has been used to treat women's conditions for thousands of years. The endocannabinoid system is intimately involved in the female reproductive tract and the menstrual cycle. The cannabis plant can be very helpful in many conditions specific to women. And finally, we need a little estrogen in every aspect of society, because estrogen makes all the difference in the world. Thank you.
So thank you again, Dr. Wilson King, so much for that presentation. Thank you for being on the panel. As you guys can see, Aaron had to leave, but I want to thank both of you, Aaron Allen and Dr. Wilson King, for being on the Women's Health panel at the Chicago Cannabis Virtual Health Fair. Thank you for your time, especially with this unprecedented pandemonium that we're going through right now. Thank you so very much. If you guys.
Thank you for this opportunity.
Mhm.
And I apologize because I talk with my hands a lot. So if that was distracting, I apologize, but
you're fine. And for our viewers, if you guys want to get in contact or connect or follow with Dr. Wilson King or Erin Allen, we will definitely leave their information within this within this presentation. So thank you again for tuning in, and thank you to our panelists.
All right, thank you. I do have a Twitter handle too.
Oh,
at
okay.
Dr. Wilson King, just to let you know that. It's at Dr. Wilson King.
So I'll have Erica reach out to you guys, and we're going to get all of your handles, and then we will put them in the presentation.
Awesome. Thank you.
Thank you again so much for your time. I appreciate it. We will definitely be in contact. So I know the last fair that we had, we were on definitely a tight budget. This one was a little bit more lax, but we had to actually change the format because of the COVID-19. Right. But hopefully we'll be doing it again next year. And so I will definitely reach out to you. Love the presentation. Thank you so much. That means
you really did like it. Okay, cool.
Yeah, it was good. It was really good. So thank you so much.
Take care. Bye-bye.
You too. Bye-bye.